Siamo a Berlino al congresso annuale dell'ESMO, la European Society for Medical Oncology, durante il quale sono presentati nuovi dati di uno studio importante, lo studio ARANOT, un trial sul tumore della prostata nel quale si è valutato il farmaco darolutamide. Noi ne parliamo con il professor Pedro Barata dello University Hospital Seidman Cancer Center di Cleveland. Professor Barata, could you give us a brief overview of the ARANOT trial, in particular its design, patient population, and primary endpoints?
Yeah, it's a fantastic question. So ARANOT is a phase 3 trial, basically randomizing patients diagnosed with metastatic hormone-sensitive prostate cancer, either newly diagnosed or with recurrent disease, to randomize in the 2-to-1 fashion to ADT alone or ADT combined with darolutamide. And it basically is an international study, ex-US study, where patients were allocated to one of these two arms. Important, the endpoint being radiographic progression-free survival, and then it had secondary endpoints of interest and important, including quality of life-related endpoints, as well as other important endpoints such as time to pain, time to subsequent therapy, etc. So from that perspective, these data leverage the use of darolutamide for men with metastatic hormone-sensitive disease without the need for chemotherapy. So it's almost like closing the loop in regards to the use of darolutamide in the context of hormone-sensitive disease.
What are the most important data that have been presented this year about ARANOT?
Right. So initially, the study showed us the primary endpoint data around progression-free survival. However, there were important aspects of the data that we wanted to see, right? One of them was indeed the quality of life. In other words, how did patients do when they were randomized to ADT with or without darolutamide, if you will? And so the quality of life data to me is important because it shows you a superiority of the addition of darolutamide to ADT reported by patients in all aspects or items that compose the FACT-P instrument. And so that to me is a very important data that's out there, basically showing that not only we're able to control the disease as defined by RPFS, but also patients do better, tell us they're doing better when they're treated with a combination. On top of that, the PSA response and the depth of response, as perhaps PSA being less than 0.2 being one of the earlier predictors of activity. Also, to me, is one of the highlights of the follow-up data that we got for the ARANOT study that deserve being mentioning because it has a meaning to patients in clinical practice.
So, and what's are the news about the ARANOT trial here at ESMO 2025?
Right. So during ESMO 2025, we'll be seeing the data in terms of efficacy, but also in terms of safety and quality of life stratified by age. Actually, in fact, age has been reasoned as an important aspect in regards to RPIs when we've seen a prior meta-analysis suggesting that older men over 75 might not benefit or might not derive the same benefit from a CYP17 inhibitor with abiraterone compared to anti-androgens. So I'm looking forward to look at the data stratified by age, because if it is indeed the case that we don't see a differential signal by age, so that's actually an important a piece of information that clinicians will take as they're treating these patients. So I think that is important. The breakdown by quality of life, safety, and efficacy during ESMO, that it might translate into what we do in clinical practice the next day.
What are the potential implications of these ARANOT findings you just mentioned for clinical decision making? Do you think all these data are practice changing?
Right. So ARANOT is an important study because it established the activity of darolutamide in the context of metastatic hormone-sensitive disease without the need for docetaxel, which was exactly what we were prior the data was released and subsequent approval of that regimen. So up to ARANOT, we had other RPIs available, abiraterone, enzalutamide, and apalutamide, approved with ADT without docetaxel. And with ARANOT, we now have the opportunity to have a fourth one, darolutamide, as an option. And I think it's important because darolutamide has specific tolerability profiles in regards to drug-drug interactions, crossing blood-brain barrier, things like mental fogginess, falls, fatigue, etc. That allows the clinical provider to consider that option in clinical scenarios. So I think is a benefit, I think is an advantage, and that approval was a consequence of this data. So it is practice changing, the fact that we have the ability of using darolutamide now without the need of docetaxel in this setting.